The other things would be about specific syndromes in women that can cause heart attacks. So we see sometimes bruising inside heart arteries, and it's just more an awareness that women have perhaps different types of heart attacks than men. And we're starting to do research in Gosford and elsewhere in Australia looking at different disorders. Spontaneous coronary dissection is one of them. And the other one relates to patients, often postmenopausal females, who have angina, but no blockages in their arteries. And that is really interesting to me. That was the subject of my PhD, and we're doing that routinely. We can actually test to diagnose why do these women have angina, and we do believe it's related often to small vessel disease in the heart, which is the microcirculation. And why is that important for women? They need to know, well, actually a CT is not going to show that. CT only looks at the big vessels, so they could be missed. And the other group is women that have propensity to spasm. And
My mum has that.
So vasospastic angina or microvascular spasm, and that's definitely more common perhaps with hormone changes with age, and it's probably underdiagnosed, and it is potentially treatable as well.
So what is that treated with hormones then, or way do you treat that?
There has been studies done, and I think they're kind of conflicting, but I think if there's another indication for the patient to go on HRT with lots of hot flushes, then I would definitely support it, because I think anecdotally I've seen patients feel better on it. But typically we would give them a vasodilating medication like a calcium blocker, and we often use that to treat high blood pressure. The challenge is that not all these women have high blood pressure, and all of these drugs are relatively dirty, for want of a better word. They're not targeted on the heart, so they often have off-target side effects. And some of the time they're worse than the symptom.
Yeah.
So mostly my patients like an explanation, and then we have a shared discussion about treating that and reducing their symptom burden.
And is that spasm potentially something that could give you a full-on heart attack?
Yeah, we definitely see a higher incidence of heart attack. I guess not all heart attacks are created equal, and the type of heart attack that we see with the common form of spasm is typically relatively small events that may not change their life, which is a good thing, but still really impact quality of life and lead to real, impairment of function and going into hospital and, prolonged hospital stays, etc. So it can be a really important thing to try and prevent for patients.
I promise I'm getting to near the end.
You're doing great. Yeah, I'm having a good discussion. And
heart failure. What is heart failure? Because it sounds very, very scary.
So heart failure is the clinical syndrome where the heart is not able to pump and keep up with the body's needs. And it's typically associated with either normal heart function, and that's more frequently related to a stiff heart, often in older women, whereas the other form of heart failure relates to a significantly weak heart. And worldwide, the most common cause of a weak heart is coronary blockages, but there are other causes as well, and genetic weakening of the heart muscles is very common as well.
If you have heart failure, is that ever reversible?
So I would say, like a lot of things, it's treatable but not curable. And to have heart failure, typically it means that there's established structural changes within the heart that will always be there. But certainly those changes are not always indelible and they're not always fixed. So examples of that are pertinent to women would be stress cardiomyopathy, or the called broken heart syndrome. And that's typically thought to relate to changes in hormones and microvascular dysfunction. And what happens is that the heart can become severely weak after an emotional or physical stressful event. And it's much, much more common in women. In fact, it's the more common cause of heart attack in postmenopausal females. So
you literally read my mind. I was going to ask you about broken heart syndrome because I had a patient who recently died within 2 days of her son dying.
Yeah.
And
would have been.
It seemed to have been from.
Yeah.
I wondered, was it broken heart syndrome?
You're right. I think without doing an autopsy, we wouldn't know if she'd had a plaque rupture, but certainly it's not all the way benign. And by benign, we meaning, we think of it as something that always gets better, but actually the outcomes, and we've seen cases really in Gosford of really severe heart attack with this, are actually similar to a blocked artery heart attack. The outcomes from the INTERTAC registry, which is one of the big contemporary trials of this, that the clinical outcomes are similar to blocked artery heart disease. So it's very important. And we still don't have a great understanding of the mechanisms and also the treatment. So there's a lot of things that we're still trying to get better at.
we seem to live in a very stressed world at the minute. Everyone seems to be busy and everyone seems to be stressed whenever you talk to them. And I know that I'm guilty of that. Do we actually have any firm data around stress and its impact on your heart health?
Not as granular and firm as what we would like, but I think anecdotally we see it is a big risk factor for coronary vascular events, and it doesn't help conditions like high blood pressure. And I think probably more work's needed, but there's not a great test for stress, and I guess it's increasingly prevalent in all of our lives. And so I guess for us as doctors, we should learn from our patients, right? So we're seeing people's lives literally every day change and take a different course. And what it's taught me as a kind of middle-aged dad is, really cherishing and spending the time leaning into the things that really matter. And part of that means, trying not to work too hard, and trying to take the time to balance, and that helps to manage what is a very stressful job, right?
Yeah.
I don't know how you manage that, but you've obviously done well with.
I've got very grey hair. Tom, is there any exercise that is too much or not good for the heart?
Yeah, I would say the really extreme forms of exercise, we do know that there's a J-shaped curve, and what we mean by that is if we do no exercise, the risk is high, and as we do exercise, the risk of events comes down. But the J-shape means if we continue to really go for really extreme, then we do see an increased incidence of things like AF, which is an irregular rhythm. And of course, we know that, really intense exercise and marathons would be one example where we do see a higher incidence of heart attacks. Does it mean that we shouldn't do it? Well, I think it's a personal decision. I think the absolute risk is quite low. And I think maybe those really extreme Ironman type competitions, probably, if you're doing an ultra marathon lasting for 3 days, probably there's a small risk associated with that. But for most of these people, and I've got friends that are into that, and whilst I like health and fitness, the extreme stuff probably not for me. But, it's part of what makes them. So I'm kind of relaxed that, people can make their own mind up. But yeah, I would say that too much exercise in that really strenuous way is probably not a good thing. And also the other side of that is, really intense bodybuilding and things like that is probably associated with its own potential risks. And
I have a couple of male patients who are a bit naughty and seem to take some supplements and things that's just safe for bodybuilding. And a couple of them they have horrendously high blood pressure, and I just really worry that they're a heart attack waiting to happen. Do you see sort of these bodybuilding types presenting with
all the time?
And is that related to the steroids and things that they're taking, or?
I think it definitely is a risk factor for things like that you talk about. High blood pressure, we're going to have more sticky blood because the blood count goes higher. So we're talking about, obviously, injectable testosterone is easy to identify, but there's peptides and there's supplements, and they probably all have some form of exogenous testosterone. And I can understand, it's part of a lot of these men's, lives, and it's enjoyable. It makes them who they are. But, I can think of quite a couple of patients I've seen in the last few years that have had, sizable MIs. And one of them is very lucky to be alive, had this huge hole in his heart, presented really late. And I think the biggest thing for him getting over this heart attack was just readjusting to life. It's like, well, training was just everything for this guy. And so I kind of empathize and try and kind of personalize treatment. But ultimately, the patient has to make their own mind up. It's not our job to tell people what to do. It's our job to guide them, and then they would make their own decision at the end of the day.
What about cardiologists who take a much more, like there's some famous cardiologists based in the US who have kind of really, I suppose, spoken out about using diet much more aggressively to reduce the need for stenting and things like that. I don't know whether you've watched any of the documentaries or read any of the books like The Forks Over Knives and things like that, which really talk about staying away from sort of animal-based foods, and that you can reverse coronary artery disease by changing your diet to a mainly plant-based diet. I just wonder what your take was on that.
I think that we can do better with diet, and I think that we need more data for these types of diets. And we're talking about really rigorously conducted scientific studies where people have a very strict diet. They're randomly allocated to this diet or that diet, and we assess clinical outcomes. But until we have that data, I think the evidence for dietary intervention changing outcome is quite weak. And my approach is really, I try to listen to what the patient is telling me in terms of what they're trying to achieve. And ultimately, if that's the way that they want to go down, I would respect that. That's their decision, and I'll sleep easy. Ultimately, it's not for me to tell them. But I think that the key thing is, family history and previous events. If you've got a strong family history of heart disease, or you've had a previous heart attack, in my mind, diet alone is not sufficient. You may be lucky, right? But statistically, if I'm treating lots of patients, that we all are, that we're going to be doing them a disservice unless we're actually getting them onto the therapy that we know is proven to reduce the risk of heart attack. For an individual, they might get lucky, and that would be good. We want to prevent troubles, but ultimately, diet alone is insufficient to control risk factors for patients that are at very high risk. That's an important message.
On Sunday morning, when I was out walking at Terrigal Beach, which is a local beach, I kept crossing paths with a number of women who all had vests on, just like me, weighted vests. And we all gave each other a bit of a knowing look, because these have become very, very popular in peri and postmenopausal women. You might not know what rucking is, but basically what it is walking with either a weighted vest or a weighted rucksack. I personally opt for the weighted vest because I find it very, very comfortable and very, very quick to put on. So for peri and postmenopausal women, there are definitely a number of health benefits that you can gain from walking with extra weight. One of the health concerns that many women have at this stage of life is developing heart disease. And unfortunately, we know in the postmenopause, the rates of heart disease for women really start to accelerate. So why might rucking or walking with weight change that? Well, basically, whenever you're walking with additional weight, it increases your heart rate more, and it basically makes your heart exercise a little bit harder. So hopefully making your heart a lot more healthy. So that's one of the benefits of rucking in comparison to standard walking. So if you're intrigued and ready to start rucking, my recommendation would be that you start low and go slow. So start by choosing a weight that is 5 to 10% of your body weight at maximum, and take it slowly. Go for maybe a 10 to 20 minute walk at first. Don't decide to go on a 5-hour hike the first time you strap on your weighted vest. So we've been chatting to our friends at Rucksack, and I've got a special discount code for you. So if you go to their website, which is www.rucksack.com, so RUKSAK.com, and use the code Shauna15, so that's SHAUNA 15, you're going to get a 15% discount. So whether you decide to go for a vest or whether you decide to go for one of their backpacks, either way, you're going to get 15% off.
This podcast and any information, advice, opinions, or statements within it do not constitute medical, healthcare, or other professional advice. Information is provided for educational and entertainment purposes only. If you have any health concerns, always consult your doctor.